Hello everyone. I welcome also everyone to today's another Sarcoma Academy webinar. We have prepared today another format. We will introduce now the case discussion format, and we have our 4 international board members who will present each one a case, and then we will be open up for discussions. And I'm hoping that there will be exciting discussions. First of all, I would like to thank you, each one of you, to prepare these cases and to share them with us and also together with your knowledge. And having said that, I would like to thank also our sponsors, foremost PharmaMar, our main sponsors, then Bayer, Novartis, and Implantcast. Without this support, this would not be possible, and that's why we are very thankful. I think we don't want to lose any time. We start with Jean-Yves Blay, who will present now his case together with the questions. Please, Jean-Yves.
Thank you very much, Bruno, and thanks to all the organizers. I'm very happy to be here with you today. I'm going to share my screen, and I'm going to present something which is not necessarily a very classical sarcoma, but I think quite instructive, at least for us. And the history that I'm going to describe is a history which can be debated at several times on what would be the optimal strategy. The story is still ongoing, as we are going to see. So this is a young patient, 23-year-old, in perfect condition, foreigner, Lebanese, living in Lyon for a PhD thesis. She has no previous history. She had dyspnea, slight dyspnea since 2 months, worsening rapidly in the last couple of weeks. And she was actually diagnosed in beginning of April 2020, suspected as COVID-19 diagnosis at this time, which proved rapidly not to be the case. Transesophageal echocardiography showed a left atrium mass, which was interpreted as a benign tumor, explaining the dyspnea. And she was rapidly, because of declining clinical condition, operated by a cardiac surgeon who performed April 14th R2 resection of what proved to be an intimal sarcoma of the left atrium. The surgeon was mentioning and called us immediately after receipt of the histological diagnosis that he had left some tumor, but as we are going to see, there were no obvious remainings of the tumor when we investigated the primary tumor region. We had a documentation upon central review of the diagnosis of intimal sarcoma and an amplification of MDM2-CDK4, which was observed on molecular analysis. I saw at this stage with a post-operative CT and a general workup, including brain CT scan, which showed no metastasis. The patient was in good clinical condition, as I mentioned. And I would like first to ask you the question of what would be the strategy in this context of R2 resected left atrial mass without options for obvious reoperation, as we have not seen something which was evident on the CT scan. So I think we have to vote now, right?
So 46% opted for adjuvant chemotherapy, 42% re-resection, and 12% for transplantation.
All right, so I do not see the results, but I heard what you just said. So the majority of, a slight majority of your proposed adjuvant chemotherapy, so-called adjuvant chemotherapy. I'm going to share again my screen because I think you don't see it anymore, right? Okay, perfect. So this is exactly what we proposed, adjuvant chemotherapy. So we selected also in brackets adjuvant chemotherapy, clearly not adjuvant, because re-resection was not an option according to the cardiac surgeon. Transplantation was something quite complex at the time of the first lockdown in France. And of course, cardiac transplantation for cardiac sarcoma is not something you can easily get done, even in particular in emergency. So we proposed 6 courses of AI. And after the 6 courses of AI, which was done basically blindly because we were not seeing any residual tumor mass, the workup showed a complete remission in August with a patient in perfect clinical condition. Again, a negative workup from brain to the pelvis. And I would like to ask what would be the strategy in this case. Again, radiotherapy, transplantation, or surveillance?
Radiotherapy, 21%, transplantation, 6%, and surveillance, 74%.
So we had intensive discussion in August and September on this question, and we shared that with a quite active cardiac transplant unit in Lyon. The fact that she was 23 in perfect clinical condition, well understanding what was going on, was of course important. I must say it was absolutely an intense debate at the Multidisciplinary Tumor Board, and radiotherapy was considered. At the end of the day, we asked the patient, with all the uncertainties that we had, what would be a preferred option given the absence of certainty of a donor for transplantation and the risk of radiotherapy. She said that she would prefer, in view of the uncertainties that we had, to have a transplantation whenever possible. And she passed through an ultra emergency procedure at the cardiac transplant unit. This is a national procedure in France, and actually got accepted rapidly, not for a transplantation, to be inscribed on the list as a priority. I think, frankly, that radiotherapy and surveillance could, of course, have been very good options. That was really debated with the patient.
Can I make a comment, Jean-Yves?
Of course, please.
So we have we have treated some patients like yours in the past years, and what we have routinely applied is proton radiotherapy. Proton, if possible, carbonion radiotherapy, with impressive results. So we have patients that are now 5 years down the line with any further recurrence, even if they had residual disease before starting chemotherapy. So I believe that, I mean, recommending transplantation in a patient with a cancer is kind of pretty much a risk.
Yeah, and you are going to see that you are absolutely right for the last part of your sentence, sadly. Yeah, actually, when I said radiotherapy, I should have been precise. We considered radiotherapy as an option for proton beam therapy because we have access to that here. But this was finally not selected. The fact that it was.
It's important to say that you need the heart gate entry. Otherwise, the risk is that you are not able to perform the right dose to the whole heart. So it's a sophisticated, I mean, procedure does not only need the right source, I mean, protons or carbonions, but also the facility to deliver the dose to the heart in the right way. So, so far, as far as I know, so far, the only gate entry for the heart is available in Boston. And the patient I'm talking to you about was sent to Boston.
You sent the patient to Boston? Okay, yeah, because actually one of the debates that took place because of the access of proton was whether the radiotherapy would be appropriate, and that was actually the proton beam guys were not very enthusiastic, probably because of what you say, Alessandro.
The gate entry, because the heart pulsates, it keeps pulsating, so you need to adjust the dose to the pulsation.
No regrets for Boston at that time. It would have been extremely complex to send her to Boston. It would still be quite complicated. But I take your point, and that's a very interesting point for the next one. Actually, in our history of patients with cardiac sarcoma with a localized tumor, we had 2 patients, long-living patients, for more than 10 years. Actually, they were published in a global series, and the only 2 long survivors were transplanted patients. This was probably something which helped us to go in this direction with the patient. Anyway, we had the resection of the heart, which was an R0 resection with not so good margin, but 2 millimeters. Impressive to look at margins on the heart, you can imagine. There were residual sarcoma cells, so it was something which was, of course, needed, or at least needed. So what would you do in this case? We are going to discuss here of adjuvant radiotherapy, chemotherapy, or surveillance. Please vote now.
No, 57% surveillance, 27% adjuvant radiation therapy, and 17% adjuvant chemotherapy.
So actually, we did surveillance. That was clearly not an option to propose adjuvant radiotherapy in this case, according to the cardiac transplanters. And we did not feel it was useful to get additional adjuvant chemotherapy, but again, with a very limited amount of information. So she was surveyed, and sadly, she was not surveyed for long. Because while she was recovering, and she was really very well recovering, because she was exercising almost a completely normal performance status, then suddenly she experienced headache very suddenly in a couple of days. And the CT scan is the one that you can see on this slide, which is, I must say, quite impressive. So there was an intense feeling of depression in the team, because that, of course, we had lost the opportunity for this patient, but also there was an art which was used probably not for the right strategy. So we have that workup, no other metastatic site. What would be your strategy?
Yeah, propose a brain transplant.
Yeah, and actually, I almost called you, but finally, I decided not. So we propose whole brain radiotherapy with no modification of immunosuppression. She was experiencing a minimal, non-clinically significant cardiac rejection biologically on cardiac biopsies. So we felt that given a very rapidly worsening performance status, she lost 50 points of Karnofsky in a very few days, that this was a logical thing to do. So she underwent whole brain radiotherapy along with Avastin to cope with brain edema. She had already corticosteroids as part of transplant treatment. So this is the last slide. And that's a summary of what happened afterwards, because I would not have bet that this was such a good prognosis, of course, after the diagnosis of brain met. But as we speak, and 2 days ago, I saw her. She's in a perfect clinical condition, PS0. Brain mets are in partial response for over 5 months, still visible, no edema, no sign of evolution. She has received no systemic treatment, but a couple of Avastin injection and, of course, immunosuppression. She underwent a true COVID-19 with PCR positive for over 29 days while she was traveling back to her family in Lebanon. She could not get back to Lyon. She married actually in March in Lebanon. She's back in Lyon to finish her PhD, and she shared with me her first article of her PhD with the defense, which is scheduled in August 2021. No treatment since brain radiotherapy, which was done 7 months ago. So this case is for me very puzzling. I don't know if I will propose that fast a heart transplant in the same situation. Again, the experience is limited. I take the note of what Alessandro just said about proton beam, but at the end of the day, it's not such bad. It was not such a bad idea, given the present situation of the patient who is feeling well and very happy with her family, with her and her husband. That was it. Thank you very much for your attention.
Well, thank you very much, Jean-Yves. Any comments from Axel and Alex in addition?
We have never proposed a transplantation to. We have treated maybe 20 intimal sarcoma, or surveillance, or radiation therapy at the end of so-called adjuvant chemotherapy in the context of residual disease. There is no enough data regarding transplantation. So
there's a major risk that the immunosuppression eventually triggers the tumor spread. And then it's very difficult to combine immunosuppression with, for example, immunotherapy if you want to get to immunotherapy at some point.
Actually, the next step that we are going to take if the patient, or should I say, when the patient progresses, because sadly, I think this is something which is going to happen. You remember that she has still no disease outside the brain. we are going to put her into in a clinical trial with an MDM2 and CDK4 inhibitors that we have in combination, which is quite well tolerated and probably feasible in the context of immunosuppression, which is relatively mild. But that's it. Anyway, what is really puzzling for me is the fact that despite an extremely aggressive and rapid brain relapse, actually she was controlled without with minor changes in the immunosuppression.
Because
so
it responds to radiotherapy. It's a clear example. It responds to radiotherapy. That's why you should have used radiotherapy.
Yeah, you're right. You're right. But she has not relapsed elsewhere yet.
Interesting enough, we have treated some patient with oral cyclophosphamide in the context of response, and we have really partial. We make a paper on the role of oral cyclophosphamide. We see the relapse in the pulmonary arterial, and we put oral cyclophosphamide and we see tumor shrinkage after 3 months. So we have some case like that. So immunotherapy in intimal sarcoma could be an option.
And you know what? Just for the sake of the discussion, we received a second intimal sarcoma of the heart in the second lockdown of France, and I did not transplant her.
And other interesting finding, we have found an NTRK gene fusion in an intimal sarcoma recently.
Oh yeah, we published. Was it the one published with Mehdi? Because we had a couple of 3 patients with MDM2 and CDK4 amplification. So she has not NTRK amplification fusion.
Next case.
Just one more question from the floor, from the audience. Sylvia is asking how you plan the follow-up.
She asked me, so I'm going to do a classical workup every 3 to 4 months. And of course, in case of symptoms, she's going to live in between Lyon and Lebanon in the forthcoming period.
Awesome. Well, thanks so much for this provocative, thought-provoking case. It's really interesting. And for staying in time, it's just perfect. So we turn over to Axel. Please present your case.
It is a male, 37 years old, autopalpation of a right mass in the perineal region in 2013. MRI, you see the MRI here, a mixed component of necrosis and dense mass near the sphincter, more or less 6-7 centimeters, infiltrating the gluteus maximus, is very near the anal sphincter. So what is your strategy? Surgery upfront, surgery followed by radiation therapy, biopsy, needle function, abdominal amputation in first, surveillance.
So we have 78% biopsy, 19% surgery followed by radiation, and 3% surveillance.
So of course we have to make a biopsy. It's complex to operate a patient without any histological results. It could be a lot of things. It is the answer is a biopsy, but unfortunately for the patient was operated upfront with a fragmented HER2 resection outside French sarcoma group centers, 6 fragments at histology. It is a myxoid liposarcoma with 25% of round cells. So it's not the optimal strategy to take in charge a localized disease. Surgery upfront without fragmented HER2 resection, 37 years old. I just mentioned the patient's advocacy group recommendation. It is not acceptable that a patient with sarcoma cannot be treated by a sarcoma specialist. I advise to you to read this recommendation performed not by doctors like ESMO recommendation, but by patients themselves. And for the funny things, it was a member of my family. So it was a cousin, was operated, and I see my cousin after surgery. So 1-2 months later, when I see the patient for the first time, we'll see with a post-operative MRI, there is a macroscopic residual disease here. We make a biopsy, confirm the residual mass. What do you propose now? So young male, good condition, R2 resection, fragmented R2 resection near the anal sphincter. What is your strategy? Upfront conservative surgery followed by chemo and radiation therapy followed by conservative surgery plus or minus adjuvant chemo, abdominal amputation followed by chemo, exclusive combination of radiation chemo or induction chemotherapy, conservative surgery, radiation therapy. There is not only one option. What is your feeling? It's complex case, young male, residual mass, R2 resection. There is few options, not only one. For me, there is two different options. I totally agree with radiation followed by conservative surgery or induction chemotherapy. It is a young situation. It is a myxoid liposarcoma, and you know the radiosensitivity of and the chemosensitivity also of myxoid liposarcoma. So R2 fragmented resection, not an easy situation, an easy site to reoperate the patient. When a patient has to be reoperated in this region, it's complex to make this kind of reintervention. I think the best option is to try to kill the different tumor residual cells before any conservative surgery. So we have proposed induction chemotherapy, not based on I put this slide because everyone are aware of the results of the Gronchi trial. Just to highlight the fact that in the myxoid liposarcoma cells, histological subtype, doxorubicin combination or trabectedine, it's more or less the same, given the same histological response. It is clearly one of the most chemosensitive histological subtype. So we have proposed 5 courses of doxo-E4 regimen. And here you have the MRI after 2 and 4 cycles. Sorry?
Can I make a question?
Yeah.
Why? So you would never have considered combining chemotherapy and radiotherapy?
Because the better is the enemy of the. We are in radiation, or we select radiation therapy or we select chemo. I know you can use chemo radiation therapy, but it's more toxic. We are near the sphincter, the anal sphincter. It is very sensitive to chemo, so we switch to radiation therapy first in case of progression. But in myxoid liposarcoma, in general, you have the tumor shrinkage or an histological response.
You can use trabectedine.
Yeah, of course, we can use it, but
radiotherapy.
Yeah, I know. It was in 2013, huh? So 2013, before the combination of trabectedine and radiation therapy. Maybe today we'll reconsider this approach, but in 2014 we have proposed 5 cycles. So, and we performed the surgery, conservative surgery, large other resection with a flap reconstruction, and it was an histological complete response. No residual tumor cells. What is your not now the strategy? Just some data regarding the histological response in soft tissue sarcoma treated with chemotherapy as induction or combination of radiation therapy and chemotherapy or radiation therapy alone. There is not a clear cutoff demonstrated a good histological response or poor histological response, as is the case in osteosarcoma or in Ewing sarcoma. But in general, whatever this retrospective trial, more you have a necrosis or more you have a few residual tumor cells, and better is the prognosis. So this patient have a complete histological response. So the prognosis for this patient could be good. I put here some the goal issue of neoadjuvant chemotherapy in general. We have to select the best patient, and sometimes the site is more important than the size. And it is the case, I put in blue the case of this young patient. Good condition, young patient, site, complex sites near the anal sphincter. We have to select the best histology, and myxoid round cell sarcoma is one of the most histological chemosensitive of sarcoma. We have defined the risk of recurrence here. If we do nothing, the risk of recurrence is 100, more or less 100%. It is a R2 resection, residual histological proven residual mass. So it's 100% of risk of recurrence. So, and the best regimen, I agree with you, it could be trabectedine plus radiation therapy, but in general, if we have to select conventional chemotherapy, we have to select anthracycline plus optimal dose of ifosfamide. So surgery, the 7th of June 2014, large resection, flap reconstruction. We are in complete histological response, no residual individual cells. What is your strategy? Adjuvant chemoradio, adjuvant chemo, adjuvant radiation therapy, surveillance, hyperthermia plus chemotherapy. More than one response possible.
So surveillance 50%, adjuvant radiation therapy 38%, adjuvant chemo 17%, and hypothermia plus chemotherapy 8%, as well as adjuvant chemotherapy alone.
So we have the two options was to continue adjuvant chemotherapy plus radiation therapy, but there is no enough data in the literature after when you propose 5 cycles in neoadjuvant situation. There is no ongoing trial asking the question of adjuvant, the same chemotherapy or another chemotherapy. There is no enough data regarding this adjuvant chemotherapy and radiation therapy. I think adjuvant radiation therapy remain, of course, the standard after an R2 resection, even in a complete histological response. You know, there is sometimes some patient relapsing locally, even in case of histological response. So radiation therapy is an important option. I put here the Gronchi-Palazzini trial. When you propose 3 induction chemotherapy before surgery, the addition of 2 adjuvant chemotherapy do not add anything comparing to 3 induction chemotherapy alone. So I think like it's not like osteosarcoma in Ewing, but especially if you give more than 3 as induction chemotherapy, more than 3 cycles, like 5 courses, there is really no indication to propose adjuvant chemotherapy. It is our algorithm here in 2021. I do not propose adjuvant chemotherapy in patients receiving induction chemotherapy, but it could be a debate. I put here what we frequently done in our institution. For R2 and R1 fragmented resection, we propose induction chemotherapy between the 2 surgery, after the incomplete and before the salvage chemotherapy, because this patient needs a salvage surgery. So it is for high-grade tumor and for myxoid liposarcoma, it is clearly there is a place to propose induction chemotherapy for this patient. So we have proposed radiation therapy, 50 gray, classical fractionation, and then surveillance. I add in the surveillance the abdominal pelvis CT scan, because maybe you are not aware on myxoid liposarcoma, but it is with lung metastasis, this patient frequently relapse in the abdominal cavity. So MRI of the thigh plus lung and abdominal pelvis every 6 months. And today it is in complete remission, normal life, active workers without any symptoms. So it is not maybe cure, but we have 7 years after the surgery. Myxoid liposarcoma, we have to be careful because it is a low grade soft tissue sarcoma, and we have some relapse after more than 10 years after the localized disease. So we have to be careful, but it is more or less what we have done for this patient, and I will be happy to have your question or suggestion. Just I finish with this slide. It is what the reflection we have in when we take in charge in Gustave Roussy a localized soft tissue sarcoma of extremity, adequate imaging assessments, diagnosis made before surgery, and discussion in multidisciplinary tumor board. The first 3 steps are mandatory. If the patient can underwent an R0 resection, upfront surgery is indicated. There is no, for me, indication of any radiation therapy or induction chemotherapy. So adjuvant induction chemotherapy or adjuvant chemotherapy remain today experimental. For non-R0 marginally operable soft tissue sarcoma, induction chemotherapy is an option and have to be discussed, even with induction radiation therapy also. And adjuvant chemotherapy is experimental. In case of mutilating surgery, there is no other option to discuss induction something, induction chemotherapy, hyperthermia, isolated limb perfusion in case of extremity soft tissue sarcoma. And of course, with locally advanced inoperable soft tissue sarcoma, it is palliative chemotherapy. The prognosis of this patient are similar to a metastatic patient. So it is more or less the discussion we have every Monday with operable, marginally operable, mutilating surgery. So, but in case of R2, R1, fragmented resected tumor, elsewhere a referral center, there is not a lot of option, and we propose induction chemo or induction radiation therapy or both if we have protocol testing these two treatments. Thank you.
Well, thanks so much, Axel. Any comments from Jean-Yves and Alex?
Concerning the multimodal approach to localized soft tissue sarcoma, we do use a lot tools like circulator to decide whether or not to give neoadjuvant chemotherapy. So we don't rely only on, we don't factor only the expected quality of surgery. So even if a patient is expected to undergo a negative margin resection, but has a risk of death, which is in excess of 40%, we do consider neoadjuvant chemotherapy anyway. But this is something which has become evident in the last years, of course. And we do more and more like that as compared to what we were doing in the past. And we combine it with radiotherapy if quality of surgery is not expected to be okay. So when we expect positive surgical margins or closed surgical margins. So we are also, well, kind of step back in the use of radiotherapy quite a bit. So we do use it every time we do believe that surgery would be marginal, and if we believe so, we do it preoperatively. If we perform a negative margin resection, there is no risk related to the possible local recurrence, local risk in terms of death. We don't do radiotherapy in the post-operative setting. Just treat the patient by surgery alone.
Today, if we have
taken in 40% of patients.
If we take in charge this patient today in 2021 in the same situation, I think we propose radiation therapy as induction, no induction chemotherapy.
Or trabectedine radiotherapy, because it's far less toxic and
I complete response. Could you hear me? Yeah,
Yeah,
high
of course.
complete response rate. Axel, I had one question for you. So clearly, this patient was missed at the beginning with the dreadful whoops, which is something which sadly still happens. If
Even
you
in
would
France.
have had everywhere.
Even in France.
Oh yes, yeah. We're slowly improving, but still we are far from that. Slowly improving. Axel, would you change your strategy if you would have the patient untouched?
No. If we start by radiation therapy alone or radiation plus trabectedine, or also it's not a mistake to make doxo for combination. Young
Yeah.
Patient, maybe if it's large and high risk, if the round cell component is, it would be nice to discuss with the pathologist what the round cell component means today, because there's a lot of confusion now with this Myxoid.
We have to have exactly the same attitude if it is an rectoanalgist, even a little gist near the sphincter. You make imatinib first to try to downstage the surgical procedure. So it is a young male near anal sphincter. So we start with an induction something, induction chemotherapy or chemoradiation therapy today.
There was one more specific question. Is there no role of administering neoadjuvant chemotherapy to prevent metastasis in certain soft tissue sarcoma subtypes with high risk? Is that anything that you consider?
We have to consider it is theoretically, when you read all the book in medical oncology, testing an induction chemotherapy in whatever oncology model, one of the objectives is to try to kill the disseminated cells not visible at the beginning but present in the body. But in sarcoma, one of the goals of induction something, radiation or chemotherapy, is to facilitating surgery. It is one of the sentences in the ESMO recommendation. More
and
than to have an
prevent
impact.
The micrometastasis.
More than to have an impact of micrometastatic situation.
Okay.
In common histology types, we use a lot of circulator. So when the patient, I'm talking about, Leiomyosarcoma, UPS, synovial, Myxoid liposarcoma, Leiomyosarcoma. We do use circulator. If outside these common histology types, it really depends on the sensitivity, expected sensitivity. So we will never treat clear cell sarcoma, alveolar surpass sarcoma, and also epithelial sarcoma is kind of.
Where do you set the cutoff, Alex?
40%. 40% risk of death at 10 years. Above 40% risk of death. Yeah. We consider.
But the 40% that you use, which looks very logical, is based on the how do you say, wet finger, or do you say seriously? That I'm convinced that 40% is very logical, but you may not exclude that between 30 and 40 you may have a benefit as well, or the same magnitude.
Yeah, but
right?
You know what's the problem? We did two kind of studies about this. The first one, the 40% comes from, of course, retrospective studies, but using data from a randomized study, where we basically split patient by percentile, and we at some point we found a cutoff over which chemotherapy proved to be more active. The other thing that we looked by looking at the larger retrospective series was whether the non-administration of chemotherapy in different sites had the same added risk according to the different circulator risk groups, and this was not the case. So the higher is the risk, the higher is the effect of chemotherapy, because this is, we don't have to forget that this is cytotoxic chemotherapy, which is supposed to work when the mitotic activity is higher. So the lower is the mitotic. It's rough, of course. It's not. It's a trivial way to look at it. We are not actually discussing in it the effect of chemotherapy in a very sophisticated way. But in a way, it's understandable why the higher is the risk, the higher is the probability that chemotherapy works. So the relative risk reduction is not the same in all risk groups. So and that's why, at the end of the day, if you select high-risk population, you pick the effect because the difference is wider compared to the low-risk groups, where in order to see a difference, you would need hundreds or thousands of patients.
Okay, understood.
Interesting. Well, I think for the sake of time, we need to move forward. There are some further questions, but we need to postpone them. Now, next speaker is Alex. Please present your case.
Okay. 8-year-old male who had back pain for 2 months, and this is the CT scan taken at the time of diagnosis with a 10-centimeter mass in the left retroperitoneum invading L4. This is back in October 2020. So what do we do here? Serum markers, biopsy, surgery.
So 96% biopsy and 4% serum markers.
Okay, a biopsy was taken. A biopsy was taken, and a diagnosis of G2 spinal cell sarcoma with feature of MPNST was made. So the question also for the expert is what now? Surgery, needed surgery, pre-op chemo, and so which chemo? Pre-op rad or pre-op chemo rad?
So each 35% vote for pre-op rad and pre-op chemo rad, and 17% for pre-op chemo and 13% for surgery.
So the thing here is that this tumor had features of MPNST, but was actually spindle cell-like. And usually in these cases where there are features of MPNST and spindle cell together, we usually test an interesting panel, which is NTRK.
NTRK, yeah.
Surprise, surprise. This was an NTRK-rearranged sarcoma.
Cool.
Which is good. It's good, but the question remains: what would you do now? I mean, surgery? Well, of course not. Probably pre-op chemo, because it's still an intermediate grade sarcoma, 10 centimeters large, and chemo does affect probably more than NTRK inhibitors the metastatic risk. We don't know this yet, but it's, we know the story of imatinib. So this is an 18-year-old male, so we are concerned of also the metastatic risk in a way. Pre-op rad, pre-op chemo rad, or Larotrectinib, because it's the one we have available.
77%, 12% pre-op chemo rad, 8% pre-op chemo, and surgery 4%.
So you see here, I mean, you really need a downstage because the tumor actually, sorry, I don't know where to put this. The tumor is, beside invading L4, is very close to the aorta here. You can see my arrow.
Yeah, yes, you can see it.
Yeah. So the more you are able to obtain a shrinkage, the better it is surgically wise in terms of surgery. So we decided to use the drug, which we expected to be the most active, and in fact, we chose Larotrectinib. And the patient was treated with Larotrectinib, and in 2 months' time, he had a wonderful response. Okay, wonderful response. Did remain a bit in the bone, but I mean the soft tissue here really, the patient had a huge response. So the question for the audience now is, so what to do now? So how long do you continue Larotrectinib?
It's a question of also of money. Larotrectinib is 300,000 euro for 1 year of treatments.
Yeah, 1 year. But now you have just given 2 months.
No, the problem is emergence of resistance. Actually, this is why we. Well, sorry.
Yeah. So how long would you treat this patient for? So he was treated for 2 months. He's 18. You got a wonderful response. Would you shift to pre-op chemotherapy, radiotherapy, combination, or surgery at this point?
I would send the patient to Alessandro Gronchi.
So surgery, you would choose surgery, right? What the others think?
So we have 48% surgery, 41% continued Larotrectinib, And each 4% pre-op chemorat, pre-op-rat, and pre-op chemo.
So we were also concerned about the risk of secondary resistances, because we don't really know when this secondary resistance occur, and if you wait too long and the patient starts growing again, you risk to have done the treatment for nothing. So it was Christmas time, the patient didn't want to be operated, so we waited 1 month longer. We continue Larotrectinib, then this is in February, so he further responded. So now what? Do surgery.
Yeah, the same. It's even simpler. You can send it to Jean-Yves Blay. It's simpler.
He's completely asymptomatic. The question is, which surgery would you recommend? Because I mean, the patient after the second day of Larotrectinib has a complete disappear. All symptoms disappeared. Complete solution of the symptoms. And now, if you go for surgery, I mean,
now
to be pretty morbid, right? Because you need to remove the vertebra and possibly the aorta.
70% go for surgery, and 26 go to opt to continue Larotrectinib, and 4% pre-op-rats.
Wonderful. So what we did at this point in time, we did surgery, and the patient underwent a resection of the residual tumor mass and blocked with L4, the spondylectomy L4. You see here the IVC, the aorta, this is the hole, so this is L3, L5, the hole with the core. Of course, this was not the only stage, it was a multi-stage operation. There was first a posterior approach, and this is the anterior approach, and when we remove the specimen. Nice, right? So this is the specimen, the vertebra, the residual tumor here, and here invading the body of the vertebra. This is the aortic bed. We left the aorta in the body of the patient. And this is the pathology. You see that the tumor was not in complete remission. There was still some reactivity to the NTRK staining, and this was the intravertebral component. So the question is now, what next? Postoperative Larotrectinib, and for how long? Chemo, which chemotherapy? RAD, chemorad, follow-up.
Should it be different to what we would have done if it would have been a non-NTRK sarcoma?
Yeah, of course.
I think, yeah.
But we would have given a pre-op RAD at least.
Yeah, of course. No, I mean in the adjuvant setting.
Ah, well, no.
So we have 44% follow-up, 24% post-op rats, 20% Larotrectinib, and 12% post-op chemo rats.
So the only thing I would never do is post-op radiotherapy. And the reason why we would never do post-op rad is because you cannot really deliver adequate dose to the surgical field in the postoperative setting, because all the area that has been resected is now occupied by normal viscera, and also there is the vertebral reconstruction, which was made through carbonium cage and posterior fixation. So I would never recommend post-op rad in any retroperitoneal tumor. That's the only thing I would never recommend. Continued larotrectomy is an option that we didn't consider because we don't have any data to support the use of larotrectomy, and as Axel was mentioning, it's costly, and we would not have had the possibility also to deliver it. But even if we had it, we would not have recommended it because we don't have data to support the use of such kind of drug. Chemotherapy, well, the patient is young, but again, we don't have a clue whether chemotherapy works in this disease. This was not an high-grade, formerly high-grade tumor. It was an intermediate-grade tumor with not with a low mitotic index. So at the end of the day, we decided for follow-up, and the patient is now 6 months. Well, not 6 months. It's now 3 months out, and he's doing well. But course, we don't know what's going to happen. But I think this was a challenging case, at least for us, because before testing and track, we were really struggling to what to do. And when we found that it was a NTRK-rearranged tumor, we still consider, the conventional approach as an option, because the conventional approach, in a way, is something that is able to reduce at least the local regional risk. Pre-op, chemo-rad would have been our choice if this was not an NTRK rearranged sarcoma. Any comment, Axel and Jean-Yves?
You have to publish this case because, to my knowledge, is one of the first cases with soft tissue sarcoma, non-infantile sarcoma, treated in a neoadjuvant setting for locally advanced soft tissue sarcoma and NTRK-positive. It's very interesting for the community.
Yeah, that's a good point. Yeah, I see. Did you look for resistance mutation in the sample which was remaining?
There was not. There was. Well, we did. Yeah, we did. We sequenced the residual tumor. We didn't find anything.
Okay, you didn't find anything.
Not yet, but it was treated only for 3 months.
I mean, that's a very, very strong story to provide NTRK testing for a widest proportion of patients, of course. I mean,
especially in MPNST-like sarcoma with epithelioid and spindle cell component, mixed component, MPNST. It is one of
not very high grade, and not very high grade. So in our hands, when you look at
not very high grade, absolutely.
Yeah, they tend to be intermediate grade, MPNST-like or fibrosarcoma-like things that looks weird. And then yes, test it, and then it's not so uncommon to find, because this was the second case in a row actually. We had another case, 3 weeks before this, and of course none. Wow. Since then no others, but it was weird actually.
Actually, we screen routinely 500 patients sequentially, and we got 5 of them, 1%.
But it's okay. But I think that if you select the right cases, eventually of course. The proportion of patients that you test and then you find that is higher, especially if you test these cases.
So there's
Alessandro, just one question. I wonder if you decided not to resect the psoas muscle in this case. It seems to be involved in the.
If I wanted, there's also a follow. We resected just the superficial part of it here, and you can see basically here that is actually retracted, but the medial aspect of the psoas was resected here.
Dear friends, I sadly have to leave you. Thank you very much.
Thank you, Jean-Yves.
Thank you. Goodbye.
Thank you so much. Alex, there are a few more questions. In an NTRK negative tumor, what would you have done up front? Maybe just briefly.
Would have done chemo or chemo-rad. Chemotherapy, because we would have valued the fact that he's a young patient, so he would have received chemotherapy first, then radiotherapy, and then surgery.
Okay, and after surgery, surveillance or?
Surveillance.
Okay. Another question is, did you use a navigation assistance for this surgery?
Not really, but this is because our orthopedic oncologist is pretty used to this kind of surgery. He does a spine resection all the time. So for a simple single vertebra, he does not use any navigation.
Yeah. And do you always screen all your soft tissue biopsies for NTRK?
Not really. We do it with the when tumors present with the features I was alluding to. So if they are not super high grade and have MPNS-like features or epithelial features or fibrosarcoma-like features, we do test them. Otherwise, we don't.
There was another question, asking for the real magnitude of the effect of the use of Larotrectinib. apart from the fact that it has a statistically significant P, when the risk calculation is made and the number of patients needed to treat to save a patient is too high.
Yeah, I'm not sure I understand the question. I think if the question is in general, I think the answer is yes. But for the patient who carry NTRK-rearrangement, I mean, the benefit you can get, I think, is super.
As you have nicely shown here, that's really impressive. Impressive case.
The tissue sarcoma families as a whole, of course, if I treated every sarcoma patient with larotrectinib without knowing whether there is a rearrangement or not, I would really overtreat a number. I mean, the benefit of the treatment would really be far less than the cost of the drug. But if you select the proper patient, I don't think this is true. This is the case.
Yeah. And there's another comment says it's not the number needed to treat, but the number needed to screen.
The screening, yeah, the screening, yeah. That's why I'm saying that if you screen the proper patient, then the proportion of positive cases would be higher. And this something is becoming clearer and clearer in these days. So the more we understand how this disease looks like, the more we understand that this is not probably just an occasional finding. It reflects a specific disease. And this is why in the new WHO, there is a class, there is a type of sarcomas, which is called NTRK-rearranged sarcoma.
Awesome.
They don't have meshed this with morphology yet, but they will come up with some morphological features that do anticipate the presence of the rearrangement, and I believe this will become a new entity.
Impressive. Thanks so much. And we are still in time. So we switch over to Javier. Please share your case with us.
Thank you very much. So I just want to share with you this case illustrating how can we manage those cases that present with bulky primary tumor in the extremity or maybe in the trunk wall, and with metastatic spread at the time of diagnosis. This is my disclosure. And the patient is 57 in the time of diagnosis year old. The first visit was in September 2017. No other relevant medical history, apart from smoker. And he presented with a deltoid mass with fast growing in the last few months. And then a core biopsy was performed with this diagnosis, Leiomyosarcoma grade 3. And the MRI was performed, seeing a deltoid mass with 15 centimeters. And the staging CAT scan revealed pulmonary multiple nodules, more than 6 bilaterally, and several lobes involved by these nodules, micronodules, and nodal regional involvement as well in axillary and retropectoral lymph nodes. So the multidisciplinary committee decided that the only surgical option for this bulky mass entail and shoulder disarticulation. And then we decided to start with systemic treatment. In that time, we recommended to enter into a JGDM trial with olaratumab plus doxorubicin, which was administered the first cycle just olaratumab in the first month, and then with the combination with doxorubicin. And in October 2017 was the patient received the first cycle, and after 2 cycles in November, clinically and radiologically progression was observed at local sites and also in pulmonary levels. So the patient became worse with more pain and function impairment. So these are not comparable because are with different scale. Seems to be the same size, but it's really not. In the right side, after the two first cycles, the tumor increased up to these millimeters. And so what should we do now after this increase, after the first line, upfront line with anthracyclines? What is your recommendation? Any comment, any voluntary comment? I don't know if the attendees can speak, Bruno.
No, I think they cannot, because we could not present the questions, but maybe we address the questions to Axel and Alex.
Oh yes, thank you.
We are in palliative situation theoretically. There is an increase with doxo or Larotrectinib. Is not a B therapy, but it's a monotherapy. We know now that Larotrectinib is not effective in soft tissue sarcoma. So, or which we can propose radiation therapy to try to block the processus because it became more and more larger. This articulation is, of course, we can do it, but in the context of metastatic situation,
yeah.
Even if the nodules are all curable by radiation therapy, stereotactic radiation therapy, we can try to make a salvage surgery, desarticulation plus local treatment on lung metastasis. But progression after one chemotherapy line, it's a challenge.
It's not good.
Right. Not good. So Alex.
I agree. I mean, I agree with what Axel is saying. So, I mean,
you would not see any limb salvage surgery options here, right?
Well, I would anyway try to do a limb preserving surgery, at least to remove the mass, because the mass is huge, and from the quality of life standpoint, it would be better not to have it. I mean, seeing it growing, and it may also limit the chance of performing other type of chemotherapy. So I would still consider to perform even a marginal resection of the primary disease, avoiding an amputation, which will not anyway save his life. But marginal resection will still be enough to control the disease for some time, which is the one we need to accompany the patient to death without quality of life issues.
Yeah, this is the challenging situation of bulky mass, and on the other side, you cannot recommend here ILP because it's beyond the axillary zone. Yes, so a few options, but in our case, we decided to recommend, as Axel suggested, radiation therapy, but in combination with trabectedine, because in our experience, these two tools are very, very effective. And actually, this is a real life case. It's not included in our TRUST trial. And we recommend the dose of trabectedine 1.5, sometimes 1.3, depend on the tolerance of the previous chemotherapy. But usually 1 hour after the stopping of the infusion of trabectedine, we start with radiation therapy. And radiation therapy with this schedule, with this fractionation, 30 grays in 10 fractions. So the tolerance is very good, and as you can see here, the patient obtained a very impressive partial response, and actually the tumor was with infection, and some suppurative drainage was occurred thereafter. But in the end, the remnant, the residual nodule was very tiny, and so surgical resection was not performed, and just to follow with trabectedine. And And this was the questions. I think this is interesting, this thought, because in second lines we don't have we don't have higher probabilities of shrinkage, because the approved drugs in second lines or beyond are rendering less than 10% usually of overall response rate. And talking about trabectedine itself alone is 9% of overall response rate, or maybe eribulin is less than 6%, or pazopanib less than 5%. And maybe gemcitabine combination could offer a little bit higher probability, but stemming from phase 2 trials. So this is, I think, is a very good option, this combination, when we have a bulky disease and in the context of metastatic spread at diagnosis, and ILP is not an option, or you don't have any experience in ILP. Additionally, the pulmonary nodules became smaller, as well the lymph node involvements. So the patient now, the last follow-up of the patient was in February 2021, this year. So free of progression, and with trabectedine, still with trabectedine. So I think this is an option, and this knowledge derived from this trial. With initially 3 cohorts, now and another 4 cohort in retroperitoneal tumors. And this is the scheme. It's very simple. After trabectedine cycle, and if as near as possible to the end of the trabectedine infusion, we start the radiation therapy. And the overall response rate in metastatic disease was 60% according to central radiology reviewer. So it's extremely high, and this is really an option in some cases. This is the waterfall plot of the phase 2 part of this trial in metastatic setting, and the high response rate translated into a longer PFS and a longer overall survival as well, at least in comparison with the historical control with trabectedine. These are some of the publications. This is the real life, and some other examples of this. Sometimes the disease was bulky as well, as our case, and the response are spectacular. And sometimes, as you can see in the pulmonary region, the response is as a black hole. I don't know, but this is a kind of response we are seeing in some immunomodulation after immunomodulation agents in sarcoma. So maybe it's some underlying mechanism explaining that. So these are the conclusions of this presentation case that I think illustrate this new option with this combination. It's safe, and not only is safe, but it's active. It's true, it's necessary to be synchronized with the radiation oncologist, and also to follow the organ constraints to give the radiation therapy. But I think it's safe otherwise, and very active, as you can see. Just to let you know this option.
Absolutely awesome. Thanks so much, Javier. Any comments from Axel and Alex?
It is an amazing case, huh? Trabectedine plus radiation therapy, 30 gray. Nice results.
Should we use this more often in these cases, this combination? Can we use this up front?
Yeah.
I don't know if up front, because we try to use trabectedine following the brochure. But in our publication from real life, we presented more than 40 patients treated with this combination, in real life, and the percentage of overall response rate is also impressive. It's not the same that the phase 2 part, because in the real life we relaxed the timings, and I think it's very important to initiate radiation therapy as close as possible to the finishing of trabectedine. So or even in the day before, because for instance Tom Chen from Taiwan is giving this combination starting the day before with radiation therapy, and also he obtained a substantial overall response rate in their cases. So maybe there is an option for some scenarios, and you know, the problem is that in second line or beyond we don't have a good option for shrinkage, and I think this concedes some options for shrinkage. I think this is my learning for this case.
I mean, clearly in leiomyosarcoma, it is one of the best histotype for trabectedine, even in advanced disease. So for locally advanced leiomyosarcoma like that, the combination very promising.
Yeah,
Alex?
and
Well, I mean, I think it's, I mean, for sure. The only thing, I mean, when it comes to talk about to localized disease, primary disease, you may have different reasons to treat the patients up front. No? So one reason may be the shrinkage, but the other reason can be the control of metastatic disease, as we were speaking before. So you don't know to which extent trabectedine has an adjuvant or neoadjuvant role in the localized setting. So we would not recommend to use trabectedine in first line, with the only exception of mixed liposarcoma. So in mixed liposarcoma, you can consider, in fact, there is a phase 2 study, which is part of this big study that Javier was discussing about, where we treated localized mixed liposarcoma patients with pre-op trabectedine and radiotherapy with impressive results as well. The phase 2 part of the study is being published sometimes later this year. So I hope it will also be useful to decide what to do in localized mixed liposarcoma patients. But besides mixed liposarcoma patients, we would not recommend the use of trabectedine and radiotherapy in other histology types, because we would prefer to use conventional chemotherapy where there's at least some evidence that that there might be an effect also in improving relapse survival and overall survival. In the metastatic setting is a different story, so I believe that this results of these studies really point to an effect of this combination, this synergistic effect of this combination that's worthy to consider whenever shrinkage is an aim, whenever shrinkage is the reason why you are actually treating your patient.
right.
There's one more question.
Agree.
Go ahead, please, Javier.
No, completely in agreement.
There was another question coming. Would you use this regimen also for metastatic mesenchymal chondrosarcoma?
Yeah, mesenchymal chondrosarcoma is managed in our site, and the recommendation is as soft tissue sarcoma, high-grade soft tissue sarcoma, and no as bone tumors. But it's true. We will start now. We will start now to Synergias trial. Synergias trial will explore the combination of trabectedine and radiation therapy beyond soft tissue sarcoma. And say that, as I explained, mesenchymal chondrosarcoma for us is high-grade soft tissue sarcoma. The management, because yes, sometimes you can use also platinum compound, is true, but some other authors are using anthracyclines plus ifosfamide as well. So I think I would not use in clinical practice because I don't have enough information, but we are generating this information we are on the way to generate this information in the Synergies trial, because Synergies trial has three different cohorts, and would include this specific subtype. But yeah, mesenchymal chondrosarcoma, if the problem is related with the tumor volume, this is an option. Obviously, this is an option. I never have tested in this case, but it's true. I have treated patients with, for instance, rhabdomyosarcoma with this combination, and the response was spectacular. Or we have treated Ewing sarcoma in 4th line with this combination, because the tumor volume was causing a very bad quality of life, and the response again was spectacular. So beyond the classic L sarcomas, or beyond the classic soft tissue sarcoma in the adults, this could work, but I cannot say publicly, but as an advice. But you know, we are generating this information in the upcoming trial. So, but it depends on the case. Obviously, this should be individualized in every case.
Well, thank you very much, Javier, for this interesting presentation. Really, really great. Well, I think we are in time, and we need to conclude. Any concluding remarks from you all, Axel, Alex, and Javier?
Axel,
I think it's a good presentation to try to discuss clinical case like that. Maybe also it will be interesting for the attendee to propose the next webinar their own case, to try to be more interactive between your center and us, to try to avoid always the same teacher to give a lecture or share a clinical case. Maybe the next step can propose to the audience to propose a case like that.
Thank you so much, Alex.
Well, I agree. I think that, I mean, discussing clinical cases is usually very informative from different point of view. So, and also engaging in a time where webinars are invading our lives. Many. So I believe at least this is engaging and entertaining, and people may like it more than other type of more didactical or conventional presentations. So I would like to thank you for having given us the opportunity to participate in this webinar, and also all the attendees who spent with us the last year and a half or so. And I hope they liked it. And my only suggestion would be to try to find a way to make it even more lively and allow attendees to be able to speak up, because I think it would make it even better.
That's what we have to do. Thanks so much. And Javier, for you?
Yes, I have enjoyed a lot the time I was able to connect. So thank you very much for your invitation. I think I have learned a lot during some presentations from my colleagues. So as my colleagues refer, I think more interactive model could be a good challenge for the next webinar. And maybe, I don't know, these cases could be uploaded in some website or platform, are very, very illustrative, very educative, and I think helpful in some way for many sarcoma caregivers. So I think the scenario has been very, very nice. The platform, the interaction of the web has been nice, but I think we need more interaction with audience. I think.
Very good. So,
thank you.
So I think just alluding on this, we plan now. Let's say we have now this website, Sarcoma Academy, www.sarcoma academy. And there we will put all the webinars online, freely available, and we try to share, let's say, a platform to make a hub for webinars, combining all existing webinars. And I think to share the cases, we also provide there the link for a forum so that we can share the cases and review them, and also in the preparation for the next case discussion platform. I think this will be a very exciting opportunities, and based on what you said, I think we have to elaborate on that. We have new opportunities with, let's say, with COVID, and I think we have to take them on. And I only thank you also for this support, and it's really a pleasure to put up all this together with you, and particularly also with all the participants. As you said, we have to improve this, that we can improve the interaction. We will do that for next time. And for all those who are not able now to speak up, please let me know what your suggestions are, what we can improve. We really want to establish something collaborative that we can all exchange independent of borders, actually. And I think today's presentations with these 4 cases were just absolutely outstanding. I mean, you made a terrific job. I mean, I'm really so happy, and I think this only can evolve any further. And having said this, again, to wrap up, I would like to thank the sponsors, foremost PharmaMar, to make this all possible. And I really hope that we can realize our dreams in the future. Having said that, I wish you all a very good night, a good time, and see you on July 1st. That's the next webinar that Javier will be presenting on July 1st, and July 16th, there will be the next case presentation as today. Thank you so much, and see you soon again.